Lovely place and this lovely meeting. I want to start out by addressing the very first issue that Professor Anderson raised, and that is the question of beliefs and morals. I have nothing morally against antidepressants. I have nothing philosophically against antidepressants. And before I got involved in this research, I believed in them. I had a clinical practice. I treated patients with psychotherapy who were very depressed. When they were very depressed, I had psychiatric colleagues to whom I referred them to get prescriptions of antidepressants. I assumed they worked. I knew they worked. They even seemed to get better, and I was sure that was due to the drugs. At that time, I was investigating placebo effects because I was fascinated with the placebo. It was an area for scientific research. I started looking for placebo effects in the area of depression because it seemed like that would be a place where one might find placebo effects. In order to do that, I had to look at drug data because where else do you get data on patients assigned depressed patients given a placebo? And that's where I got the first big surprise of my life when I found that the difference between placebos and antidepressants were much smaller than I ever could have imagined. After my first meta-analysis, my colleagues and I petitioned the Food and Drug Administration to get all of the data that the pharmaceutical companies had sent to them in the process of getting the drugs approved. Because I agree with Dr. Anderson that in order to look at the evidence, you have to look at all of the evidence, not just a subset of it. And that was an advantage. It's an advantage that you have when you get the data files, the statistical files from the Food and Drug Administration, because they include data on all of the adequate and well-controlled studies, judgments made by the FDA as to whether the studies were adequate and well-controlled, submitted to them by the pharmaceutical companies. That's both the published data and the unpublished data, and that's very important because 40% of the trials sponsored by the pharmaceutical companies in the treatment of depression are not published. And if you looked at the published trials, yes, you get a clear effect. More than 3/4 of them show a statistically significant benefit of drug over placebo. But when you look at the unpublished trials, 88% of them show no significant benefit at all. So what my colleagues and I did was to put together all of the trials, the published trials, and the unpublished trials, and analyze them looking at changes that were produced on the Hamilton Depression Inventory. A large clinically significant benefit for patients being given drug, a large clinically significant difference for patients being given placebo. 82% of the benefit obtained by the drug was also obtained by the placebo, leaving only 18% as a true drug effect. The mean difference was 1.8 on the Hamilton scale. And as you heard, NICE, although they've now taken it back, set the criterion for clinical significance at 3 points. Nowhere close. Now, is this an arbitrary difference, this 3-point criterion, or is it a liberal criterion for a drug placebo difference to be clinically meaningful? Consider this. One can get a 2-point difference on the Hamilton scale if the patient stops playing with his or her hair, or acknowledges being depressed, or falls asleep easily, or doesn't wake up in the middle of the night, or doesn't wake up earlier in the morning. That's about the size of the difference that, in fact, we obtained putting the published and unpublished trials together. You can get a 4-point difference with any 2 of those changes and no other changes at all in symptoms of depression. Yes, the criterion is arbitrary. Almost all of our criteria are arbitrary, necessarily so, but we need to have them nonetheless. The criterion of 0.05 for statistical significance, that's arbitrary. We shouldn't throw it out. It's useful, but it's arbitrary. The idea that a response is a 50% reduction in symptoms, which is how we measure response rates, that's arbitrary. The idea that remission is less than 8 points on the Hamilton scale, not less than 7, but less than 8. It's arbitrary. All of these are arbitrary. So is the 3-point difference. One has to have a criterion. Unfortunately, Dr. Anderson's panel has taken away the only criterion that had been proposed and not substituted another one for it. Skip this. We published these data first in 2002, and the response was that the patients in the clinical trials were not depressed enough, a response that was echoed to some extent by the previous speaker. So we went back in 2008 to the same data set from the FDA and applied the criterion that you've heard about, we'll talk about in a minute, for moderate, severe, and very severe depression. We found only one trial that involved moderately depressed patients, showing basically no difference at all between drug and placebo. None of the trials were done on severely depressed patients. All of the rest of the trials were done in patients in the very severe category, not reaching the NICE criterion. However, you'll notice that there's a trend. And if you break that very severe category into two, you find that people with depression scores 28 or better on the Hamilton do have a response, a drug-placebo difference that exceeds this very liberal criterion that NICE had used for determining clinical significance. Now, are those severe, very severe categories, how realistic? Are they not, are those categories maybe biased and really what are being called very severe are not very severe? How can we judge that claim that Professor Anderson has made? Well, here's one way. These are the results of a study that was done just looking at the severity of depression of patients in clinical practice who are diagnosed with major depressive disorder. What are their depression scores on the Hamilton Depression Inventory? Here's how they are distributed in the clinical population. This is in Rhode Island. Just taking everybody who got that diagnosis, hundreds of patients, and giving them and scoring them on the Hamilton. I've also looked at the baseline data in the STAR-D trial, very similar to this. There's where you get a clinically significant benefit. It's in about 10% of the patients. The rest of the patients do not show a clinically significant benefit. If you look at the newest drug that's been approved by the FDA, vilazodone, you get even worse results. The first 5 trials couldn't find even a statistically significant benefit. They added 2 more, which did find a small statistically significant benefit. As you can see, the drug placebo difference on the Hamilton scale, a 51 or 52-point scale, is 1 point. I wonder whether you would argue that that is clinically significant as well. Our study and our results have been independently replicated in an article published in the Journal of the American Medical Association in 2010 by Fournier and his colleagues using raw data from 5 different clinical trials where they were able to get the raw data. Looks very much like our results, does it not? The only difference was the breaking point on when you reach clinical significance using their data was 27 rather than 28 points on the Hamilton Depression Scale. Now, there is, for the 85 to 90% of people who don't reach that threshold, for some of them, for those in the severe and very severe range, not for the moderately depressed patients who are actually the bulk of depressed patients, there is a statistically significant drug effect. The question is it a real drug effect, or might it be an enhanced placebo effect? Why an enhanced placebo effect? Because in clinical trials, patients are given, have to give informed consent. They're told that they might be given a placebo. They're told it's double-blind. They're told that the therapeutic effects may take weeks, and they're told that there are side effects, and they're told what the side effects are. They're told you may have sexual dysfunction, you may get nauseous, your mouth might get dry, and so on. So naturally, a patient wonders, to what group have I been assigned? Am I in the drug group, and am I in the placebo group? My mouth's getting dry. My mouth's getting dry. I must have been assigned to the drug group. Now I know I'm in the drug group. Person in the placebo effect in the placebo group doesn't have these side effects. They don't know what they've been assigned to. Does knowing make a difference? Well, just to show why side effects can make a difference, therapeutic effect of imipramine, side effect difference of imipramine. There's a big, big difference in side effects. It leads people to break blind. Most people do break blind, especially if they've been assigned to the drug group. Their physicians break blind. Does breaking blind make a difference? Here's the result of being in the response rates in two kinds of clinical trials. One is a clinical trial in which there's a placebo control, and so you know that you have a 50% chance of getting a placebo. Response rates are 50%. This is a meta-analysis across many, many, many trials. Comparator trials where you know that there's no chance at all of getting a placebo. Response rates are 60%. The difference is statistically significant. I will skip this. Yes, I won't skip this even though this wasn't mentioned, and that is that the trials are too short. They're, after all, 4 to 8 week trials, not enough time to show an antidepressant benefit over placebo. Here's a recent meta-analysis this year, conducted by the FDA themselves, on their own data. Probably the largest meta-analysis done, larger than ours. They separated the trials into 6-week trials and 8-week trials and measured what is the likelihood that the trial showed a significant drug-placebo difference. In 6-week trials or less, 75%. In 8-week trials or more, 38%. Here's what NICE said in 2004. In all trials put together, when you looked at all of the trials, the effect size was 0.34, far from the criterion they had set for clinical significance. In trials 8 weeks or longer, the effect size was 28. Another claim that's made is that the people going into clinical trials are not representative of the clinical population. And that's true. They're volunteers. Subjects are advertised for. People with comorbid conditions are excluded. People with chronic conditions are excluded. People who are suicidal conditions are excluded. It was for that reason that the STAR-D trial was conducted. Gigantic trial, gigantic multi-center trial with really many, many centers. Maybe the largest clinical trial of antidepressants, but without placebo controls. No volunteers, No advertising for subjects, included patients with comorbid conditions, included patients with chronic depression, included patients who were suicidal. 79% of the patients in the STAR-D trial would have been excluded in a clinical trial. What are the results? Well, here are the results from the Fournier meta-analysis, the one that was a meta-analysis. It was really a pooled analysis of the raw data of 5 clinical trials that replicated almost perfectly the analyses that we had done of the FDA trials. 50% response rate on drug, 36% remission rate on drug. STAR-D among patients who would have been included in a clinical trial. 52% response, 40% remission. Very good. What about those patients, the 79% of the patients in the STAR-D trial who would have been excluded from a regular clinical trial? At step 1 of the STAR-D trial, 34%, 25%. They are less responsive to drug than patients in the FDA database or in clinical trials generally. You give them 4 different treatments. I don't know why we were shown theoretical response and remission rates when we have actual ones. You get small benefits from being switched. But then you follow people up for a year after they remit, and here's what you get. At 3 months, 6 months, 9 months, and 12 months. After 1 year, 93% of the patients who had remitted had relapsed. Weigh those benefits against the risks of antidepressants. There are, of course, the side effects, which for SSRIs include sexual dysfunction rates of up to 80%, weight gain, long-term weight gain, insomnia, diarrhea, nausea, etc. Withdrawal syndrome that can affect up to 20% of patients, and these additional increased risks. One that's been debated here, increased risk of suicide in children and young adults, according to the FDA, on a meta-analysis of the largest database that we have, including unpublished data as well as published data. Death from all causes, an increased risk of 32% in 6 years. Increased risk of stroke of 45%. Increased risk of birth defects when women who are pregnant use it in the first trimester, often not knowing that they are pregnant. Increased risk of autism in the offsprings of women who use it in the first trimester, 280%. And this probably will surprise you the most. Increased risk of relapse of between 113 and 288%. Where does that come from? Here are the data from meta-analyses that Professor Anderson was talking about. You give people an antidepressant. They get better. You take them off the antidepressant, about half of them relapse. If you keep them on the antidepressant, only 23% relapse. Oh, that means that the antidepressants are protecting you from relapse, except that omits one other kind of data. What about people, as are seen in continuation trials, who remit on the antidepressant and are kept on the antidepressant? What is their relapse rate? 23%. Now, that may be due to breaking blind, but there's another possibility. Breaking blind because when you're switched from the antidepressant, you know from the change in side effects, so you're more likely to break blind, although that should, much of the relapse can occur perhaps too late for that to make sense. But there's another possibility, and that is that antidepressant use, even for 4 to 8 weeks in an acute clinical efficacy trial, might induce a vulnerability to relapse. Here are some of the data for that. The risk of relapse varies with the kind of antidepressant you were on. The more the antidepressant enhances serotonin and norepinephrine in the brain, as found in rat studies, the greater the risk of relapse in human studies. Here's the chart showing that in a meta-analysis recently published by Paul Andrews and his colleagues. That's one piece of data. If that doesn't convince you, consider this study on the effects of exercise in antidepressants, SSRIs in particular, on depression. 3 groups. Patients randomized to 3 groups. One group is given exercise training for over a 4-month period. Another is given SSRIs over a 4-month period. Another is given SSRIs and an exercise program over a 4-month period. At the end of 4 months, no significant differences in remission, although the no numerical difference seems to favor the combined treatment. But what happens when you follow people up at 10 months in terms of relapse? The exercise group, only 8 people relapse. SSRI group, almost 40% relapse, and more than 30% relapse in the group given both exercise and SSRIs. If you look at who is in remission, what percentage of patients are in remission after the 10 months, greatly favors the exercise group, but not the exercise plus SSRI group. SSRIs seem to increase the risk of relapse. Here's the degree to which that happens from the same data that I just showed you. You have an increased risk of relapse of 288%, a decreased chance of being in remission of 36% after 10% as a function of an initial 4-month trial in which antidepressants were or were not included. Professor Anderson talked about the tryptophan depletion studies. Let's look at those data a little more closely. Tryptophan, as you know, is an essential amino acid. It's the precursor to serotonin. If you give people a beverage containing all the essential amino acids except tryptophan, you lower tryptophan by 80%. And that results in a lowering of serotonin levels in the brain. You give tryptophan to healthy control subjects. How many of them become depressed clinically? None. You give them to people who have remitted on SSRIs. How many of them relapse? 47%. But that's not the whole story. Let's look at the data now in terms of mood change. Healthy controls, you get some negative mood change. Tryptophan blocking decreasing the serotonin levels produces some negative mood, not enough to cause relapse. That was where you had none of them becoming clinically depressed. Patients on SSRIs, this is the 47% relapse in terms of how much mood change there was. What about people who are on drugs that didn't affect serotonin? They were on NDRIs. They're just like healthy controls. There's something about the SSRI, about the drug that that increases serotonin levels in the brain, that is increasing relapse and decreasing mood when you do when you deplete tryptophan. What about patients who are in remission but are no longer on medication? What happens when you give them tryptophan? I have to change the scale of the graph to show you that. There are no other data sets in which I've ever had to do this before. Because here is what happens. Now, what is the time course at which you get this massive decrease in mood from patients who remitted and then have been tapered from the antidepressant? Length of time off meds. To show you this is a function of the length of time off meds, again, I have to change the scale of the graph. There appears to be at a window of vulnerability between 3 and 6 months after people are taken off of SSRI medication when they are particularly sensitive to having their serotonin levels decreased by tryptophan depletion. So, am I arguing that we should prescribe placebos? No, I am not. Partially because we don't have to. Here's what we know. If you prescribe an antidepressant, you get about a 50% improvement in depressive symptoms. If you prescribe a placebo, you get about a 40% improvement in depressive symptoms. This is, by the way, from a massive meta-analysis done by Khan and his colleagues, including, but not limited to, the FDA data. You have to do something, however. You have to do something to treat depression. People just put on a waiting list, don't improve much spontaneously, but there are all kinds of alternatives. There is psychotherapy, which gives you the short-term benefits of antidepressants and has the added benefit, and I'll show you that in a minute, of blocking relapse. Adding psychotherapy to antidepressants in trials in which the ratings of outcome were done blind, as it's true of all of the trials in this meta-analysis, not much different than either antidepressants alone or psychotherapy alone. Alternative treatments, which included acupuncture, exercise for patients with major depression, about the same. There are all kinds of treatments that work that don't carry the risks that antidepressants carry. Psychotherapy in particular, this is a 2-year and 4-year follow-up of patients initially assigned to given short treatment of citalopram and then either followed up with clinical management or given 10 weeks of CBT, of cognitive behavior therapy. At 2-year follow-up, the difference in relapse rates, and in 6 years, the difference in relapse rates. My conclusions: when should you use antidepressants in patients with major depressive disorder? Yes, there is a place for them, despite everything that I've said. They should be used in cases with extremely severe depression, meaning people within the most severe 10 to 15% of the patients with major depressive disorder, because those are the ones who score 27 and above on the Hamilton Depression Inventory, where you do get a clinically meaningful difference. And you should use it only when other remedies have been tried first and have not worked. That's my book, most recent one. I thank you very much.